بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. مرحبا بكم جميعا في هذا اللقاء. معنا اليوم مجموعة من الأطباء المتميزين، ومعنا كذلك ضيوف من ليبيا ومن أمريكا، زملائنا في تخصصات أخرى واللي لها علاقة بموضوع اليوم. فنبدأ بتعريف الزملاء. Dr. Salah Elbadri, who is a heart failure consultant and works at the Advanced Heart Failure Unit in Qatar. He's also the Associate Program Director of the Cardiology Fellowship there. ما شاء الله. معنا أستاذنا الدكتور المميز دكتور عبد الرزاق الجهاني, who is a Senior Consultant and Interventional Cardiologist and Professor of Medicine and the Chairman of the Heart Center في قطر. معنا ضيوفنا اليوم دكتورة سامية الميلادي, استشارية باطنة وسكر والغدد الصماء من بلدنا الحبيب ليبيا, جامعة طرابلس, كلية الطب البشري, قسم الباطنة. ومعنا دكتورنا منير محمد, Assistant Professor في University of Queensland, Australia. كذلك he's a nephrologist in New Orleans, Louisiana, in the United States of America. ومعكم أسامة القصبي من كندا. ما شاء الله, يعني احنا 6 مليون ليبي لكن موجودين في جميع أنحاء العالم, فمش عارف لو كنا أكثر شو كنا نديره يعني. فالحمد لله على كل حال. موضوعنا اليوم اللي هو SGLT2 inhibitors and cardiovascular outcomes. without further ado, دكتور صلاح تفضل.
السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Osama, for the introduction. And thank you for your continuous effort with Dr. Ayman as well and all our colleagues inside Libya and outside. I'm delighted today to talk about SGLT2 inhibitors and the cardiovascular outcomes. So my objective today I'll be talking about burden and complication of diabetes and the role of SGLT2 inhibitors and the primary prevention, SGLT2 inhibitors and heart failure with reduced ejection fraction, and SGLT2 inhibitors and heart failure with mildly reduced and preserved ejection fraction. And the big question to start with is, are they diabetes, renal, or cardiac drugs? And I will start with a clinical case. This is a 67-year-old male hypertensive smoker complaining of dyspnea and orthopnea. He came for routine follow-up, and he has NYHA class 1 dyspnea. He was euvolemic stable. And for the first time, his hemoglobin A1C, 7.8. So he is naive to anti-diabetic medications. You can see his echo with severely reduced ejection fraction and LVH. So he has a structural heart disease and heart failure. Now, what do you think about his cardiovascular risk according to the new diabetes guidelines? Is it high, very high, or moderate? So all of you, I think, will choose very high, and this is based on the new guidelines, 2019 European Society of Cardiology guidelines on diabetes and pre-diabetes. This was with a collaboration with the European Association of Study of Diabetes. And this is the definition of very high risk. Patient with diabetes and established cardiovascular disease, like in our case, or with other target organ damage, or 3 or more major risk factors, or type 1 diabetes of longer than 20 years. So this category is very high risk. The high risk is patient with diabetes more than 10 years with other additional risk factor. And for moderate risk is a type 1 diabetes less than 35 years, or type 2 diabetes less than 50 years, and with the diabetes duration less than 10 years. Why it's important to classify them? Because the treatment depends on risk stratification. And here we have another question. Which glucose lowering agent to start with? This patient is drug naive. Should we start with metformin, dapagliflozin, insulin, or saxagliptin? So saxagliptin, you know, saxagliptin is one of the DPP4 inhibitors, and it is contraindicated in heart failure, associated with like 27% risk of hospitalization because of heart failure. And is it metformin or dapagliflozin? Like most of you will choose dapagliflozin because they talk about SGLT2 inhibitors. But let us look to the guidelines. Now, the pathway is like that. I mean, the treatment algorithm is like that. If the patient has no risk factors or moderate risk factors, then we start with metformin. And if the hemoglobin A1C above target, then we can add other medication like SGLT2, GLP-1, or DPP4. If not, then we add other class, and we'll reach to sulfonylurea or basal insulin. This is for a low risk or moderate risk or no risk. Now, for our patient is a very high risk. So for very high risk or patient with established atherosclerotic cardiovascular disease, if he is drug naive, we'll start with SGLT2 inhibitor or GLP-1 receptor agonist. GLP is glucagon-like peptide 1 receptor agonist monotherapy. So because they are associated with improvement in cardiovascular outcome. Now, in our case, the patient has additional thing, which is heart failure. So the SGLT2 inhibitor will be the best choice for him. And if the hemoglobin A1C above target, then in this case, we add metformin. And if still above, we go with other medications until we reach to the basal insulin and sulfonylurea. Diabetes is a global pandemic, and in Middle East and North Africa, it will be increasing up to 108 million in coming 2 decades. So it is a real global pandemic, and it's more in our area. As you know, we have 2 main complications of diabetes, microvascular and macrovascular. Microvascular complication, retinopathy, nephropathy, and neuropathy. And macrovascular are stroke, coronary artery disease, peripheral artery disease. So for microvascular complication, we can treat with the strict hemoglobin A1C control. But this is not true for macrovascular complication, and we'll come to that in the lecture. So we have macrovascular and microvascular complication, but we should not ignore the most frequent, forgetting fatal complication, heart failure. One of the most common cardiovascular complication of diabetes, most disabling and deadly complication of diabetes, very high rate of subclinical heart failure and diastolic dysfunction, and effect of anti-hyperglycemic agents vary. And if you see the story of heart failure, start from stage A and B, where we have a preclinical stages, where prevention is very important, because once we reach a clinical heart failure, stage C, then we'll have multiple exacerbation and we'll reach a stage D, or the refractory heart failure. And it is a progressive disease. It will progress, will not regress. So prevention is very, very important in heart failure. 1 in 5 people will develop heart failure, and number one cause of hospitalization in people more than 65 years. 30% of those admitted to hospital are readmitted within 90 days, and 30% will die within 1 year of heart failure hospitalization. 50% die within 5 years. So it is very malignant disease. Quality of life is very important, and improving heart failure symptoms and quality of life continues to be unmet medical needs in patients with heart failure. And this is taken from Minnesota Living with Heart Failure Questionnaire. If you see here, patients were asked whether their heart failure prevented them from living as they wanted in the past month, and the high impact was for staying in hospital. So if you want to do one thing good for heart failure patient, keep them away from hospital. So treatment goals for patients with heart failure: prevent heart failure hospitalization as first aim, prevent, relieve symptoms, improve quality of life, increase functional capacity, and improve survival if we could. Still a high unmet need for heart failure. And we have to improve outcomes and manage symptoms, frequency, and burden, simplify dosing schedule, and achieve positive impact. This should not be an expense of safety or preservation of kidney function. And we should not have minimal contraindications due to polypharmacy. The pathophysiology leading to clinical events is very complex, and it's multifactorial. And we should not forget the oxidative stress. This is very important factor. And in the past, we tried to prevent cardiovascular disease and improve cardiovascular outcome by intensifying glucose target or intensifying treatment to reach very low target. And it was not successful. See here in 2 trials, ADVANCE and VADIT, were neutral, while in ACCORD, no achievement of cardiovascular outcome improvement, and there was also a trend for mortality. The possible reason here is the hyperglycemic memory. So we have a hyperglycemia, then we have, as part of oxidative stress, a reactive oxygen species. Even if we reach normoglycemia, then we have persistent of Ross-mediated hyperglycemic stress and continuous endothelial dysfunction. We'll come to the new kid of diabetes. Actually, it's not a new kid. It's an old guy, and he was born in 1834. It was isolated from bark of apple tree and called florizin. It was discovered to have a high ability to increase the urinary glucose excretion. In 50s, discovered to inhibit renal glucose reabsorption, and administered to mice and blocked hyperglycemia after ingestion of glucose. It was not practical to use it because it was SGLT1 and 2, and it was like associated with significant GI symptoms like diarrhea. And the first florizin analog developed in 1999, and 2003, the first SGLT2 inhibitor tested in human, and in 2012, dapagliflozin was the first SGLT2 inhibitor approved in Europe. You see the reduction in hemoglobin A1C is modest around 0.6. And this is a possible reason that's well tolerated even in non-diabetic if you use the SGLT2 inhibitors in heart failure for non-diabetics. Now, the story started here actually in 2007 and 8, If you remember, the Avandia, rosiglitazone was abandoned because of the increased risk of myocardial infarction. And FDA requires that new therapies not associated with an unacceptable increase in cardiovascular risk and must be non-inferior. So they mandate that every single anti-diabetic, new anti-diabetic should go for like safety trials. And here we have the three famous safety trials for SGLT2 inhibitors: EMBA-REG for empagliflozin, Canavas for canagliflozin, and DECLARE for dapagliflozin. So they were the 3-point MACE endpoint achieved in EMBA-REG and Canavas, and was non-inferior in DECLARE. The 3-point are cardiovascular death, non-fatal MI, and non-fatal stroke. What was not expected in these trials, that we will have a decrease in heart failure hospitalization and cardiovascular death in the three trials. 34% reduction in empagliflozin, 22% in canagliflozin, 17% in dapagliflozin. What was additional benefit here is the renal-related composed outcomes across all three trials. So in 2008, or before 2008, hemoglobin A1C, the lower, the better. And then in 2008, hemoglobin A1C, the lower, the better, but without weight gain, hypoglycemia, and side effects. And now it's a multifactorial cardiovascular risk, including blood pressure, LDL, cholesterol, glucose lowering, with agents of proven safety and efficacy. And the EMBA-REG was in 2015. So in 2016, the heart failure guidelines, they mentioned empagliflozin should be, or they recommend empagliflozin to be class 2A in patients with type 2 diabetes in order to prevent or delay the onset of heart failure and prolong life, because there was improvement in mortality in the EMBA-REG trial. EMBA-REG trial was different than DECLARE and Canavas, because 100% of patients were like with established atherosclerotic cardiovascular disease, while in DECLARE, 60% of the patients were like with only risk factors without established, so population difference. In 2001, the guidelines included all non-SGLT2 inhibitors are recommended with type 2 diabetes at risk of cardiovascular events to reduce hospitalization for heart failure, major cardiovascular events, end-stage renal dysfunction, and cardiovascular death. So the beneficial effect of SGLT2 inhibitors in clinical and preclinical studies, it improved glycemic control, lower blood pressure, reduced stroke risk, improve renal outcomes, weight loss, improve cardiovascular outcomes. And the question, how do they work? This is a tough question to be asked and usually avoidable, but you know, we have a lot of speculations. One of them is the effect of diuresis, natriuresis, glycosuria, the theory of sodium hydrogen exchanger. Here we have the SGLT2 inhibitors blocking the sodium hydrogen exchanger, and this will lead to less sodium and calcium, less mitochondrial damage and more ATP production, and less cellular damage. And we have here another theory saying that SGLT2 is not another expensive diuretics. And the interstitial edema and heart failure, the SGLT2 will selectively reduce interstitial edema, while other diuretics like loop diuretics will affect both interstitial edema and intravascular volume, so lead to hypoperfusion. We go further for the favorable effect in renal effects, diuresis and natriuresis, reduction in extracellular volume, improvement in loading conditions. And more important is the vasoconstriction of the afferent arteriole. This leads to the reduction in the, improvement in the hyperfiltration. The hyperfiltration is the problem usually in developing chronic kidney disease. So by vasoconstriction of the afferent arteriole, we have a dilatation of the efferent arteriole and reduction in the GFR, and this is the basis of renal protection. The SGLT2 inhibitors are the only anti-glycemic drugs that promote gluconeogenesis and ketogenesis, increase hematocrit by stimulating erythropoietin and not by hemoconcentration, and reduce the serum uric acid. Uric acid is a cardiotoxic substance. And in statistical mediation analysis of large-scale randomized controlled trial in diabetes, the two most important drivers of the effect of SGLT2 inhibitors to reduce heart failure and renal events were increase in hematocrit and decrease in uric acid. To take it further, this is a new theory, nutrient deprivation. So by caloric loss, the glucose will be lost in the urine. Body will think that it's starving, so we have a nutrient deprivation signal, something called sirtuin, and this will lead to hypoxia-induced factor, which is increase the erythropoiesis. And the other hand will have inhibition of xanthine oxidase, and then we'll have a less uric acid. So there's a lot of theories and speculations, but at the end, I don't think we should care. The medications or the SGLT2 inhibitors, they do work, and we don't care about the mechanism. It's for other anti-failure treatments, so you'll have similar story. So caloric loss in the urine may be beneficial in this theory. What's important is the finding, the direct and indirect action of SGLT2 inhibitors to have the benefit. We know that we will have a less cardiac preload, improvement in ventricular remodeling, improvement in systolic function and diastolic function, less fibrosis, improvement in the endothelial function and hematocrit. And natriuresis is important, uric acid reduction, and lipolysis, and improvement in the glucose and insulin resistant. So these are about the diabetes trials and the story of safety trials, and then we start to think if they are effective in preventing heart failure, whether they are effective in treating heart failure with reduced ejection fraction to start with. And what should be ideal for HFrEF therapy is one pill once per day with no dose titration, a substance which would improve survival and prevent hospitalization, and benefit appear rapidly within days to few weeks of initiation. And since 1991, we started a success in heart failure therapy with heart failure with reduced ejection fraction. In 1991, before 1991, we were using diuretics and digoxin. And then in 1991, follow SOLVE trial and consensus trial, we added ACE inhibitors. In 1999, before that, beta blocker were contraindicated. We add beta blocker to the treatment, and we achieve a more reduction in the cardiovascular mortality. And then in 2008, Fayazanad added MRA to the treatment. And in 2014, we have the success of a very large trial, the Paradigm trial, where the ARNI showed incremental benefit of 20% above the previous treatment. And we continue the success. And in 2019 and 20, we have the HFpEF and imperial reduced, where the addition of SGLT2 inhibitors to the standard of care lead to relative risk reduction of 26%. This leads to change in the guidelines. So we have two sister trials, HFpEF and imperial reduced. The two trials are similar. HFpEF was in 2019, imperial reduced to 2020. The difference may be in the population. You see here, they include both patients with HFrEF, ejection fraction less than 40, age more than 18, and NYHA class 2 to 4. The difference here in the inclusion criteria, the imperial reduced trial included more sick patients. So they mandate the proBNP to be high if you are including patient with a higher ejection fraction. While in HFpEF, the proBNP was for all more than 600. If you need to include patient more than 36 to less than 40, you need proBNP to be 2,500 or more. And then the GFR also was difference in the inclusion. In imperial reduced, it was less than 20, while in HFpEF, less than 30. So these two trials, they contain the two arms of heart failure. The patient, we call them stable heart failure or less sick heart failure, and the other arm with a more sicker population. And both trials, we achieved cardiovascular death and heart failure hospitalization. First, in HFpEF, dapagliflozin reduced the risk of primary composed outcome in patients with HFrEF by 26% with a significant p-value. Interesting here, you see the separation of the curves very early at 28 days when you start dapagliflozin. What's more interesting, because this patient included diabetes and non-diabetes, actually the non-diabetes were more than diabetic patients. 55% of patients were non-diabetics. And both achieved the primary endpoints without interaction. The other study is the imperial reduced. The empagliflozin also lowered the rate of cardiovascular death or first heart hospitalization in HFrEF patient by 25%, and see very early separation of the curve, very early and sustained risk reduction in cardiovascular death or heart failure hospitalization. The same, it was, the risk was reduced regardless of diabetes status. Diabetes and non-diabetes both got the benefit. As a key secondary endpoint, empagliflozin lowered the rate of total heart failure hospitalization, first and recurrent in patient with HFrEF, 30% relative risk reduction. This is one very important incremental finding in imperial reduced trial. The composed renal endpoint, end-stage kidney disease, requirement of dialysis, it was reduced by 50% in this trial. So they work regardless of pre-existing condition, diabetes, CKD, regardless concomitant medication, ARNI or MRA. So these patients were well-treated patients. And regardless of kidney function, GFR, they include up to 20 GFR of 20 in imperial reduced trial. despite all guidelines, it's very, very difficult, you know, to keep patient on anti-failure treatment. In the target dose we achieved in clinical trials, we have a problem with the blood pressure, heart rate, you know, CKD. Tolerability is a problem. So patient profiling is important in prescribing anti-failure. For the SGLT2, maybe it's one size fits all, because irrespective of CKD, or it's minimally decreasing blood pressure. So it is usually tolerated medications. So in the European Society of Cardiology guidelines, we have the 4 pillars now all together in one line. We should start them all together to treat patients with heart failure with reduced ejection fraction, to decrease the risk of cardiovascular mortality and heart failure hospitalization. Now, quadruple therapy instead of triple. And we should start them together instead of sequential. If you see here, this is a cross-analysis between cross-analysis for emphasis trial, paradigm, and DABA-HF trial, and compared conventional therapy to comprehensive therapy. Conventional, that means ACE inhibitor and or ARB and beta blockers, or comprehensive altogether, the 4 medications. We achieved in a patient with at age of 55, looking for time to first hospitalization or heart failure or cardiovascular death, we achieved additional 8.3 years free from first heart hospitalization or cardiovascular death. And this is the HFrEF. What about the most difficult part of heart failure with preserved ejection fraction? You know, there have been clinical trials, multiple, up to 5 trials since 2013, SHARM Preserve, PEP, CHF, I-Preserve, TOPCAT, Paragon. None reached their primary point. Some of them just marginally missed the statistical significance, like in Paragon trial, but none reached their primary endpoint until we have the Elbadri Preserve trial in 2021. This was the first success in HFpEF in patients with heart failure with reduced with ejection fraction more than 40%. Empagliflozin demonstrated 21 relative risk reduction versus placebo in the primary endpoint of cardiovascular death or heart failure hospitalization. So in Elbadri Preserve trial, they investigate safety and efficacy of empagliflozin versus placebo in patients with heart failure with preserved ejection fraction, included diabetic and non-diabetics patient aged more than 18 with chronic heart failure. And they were randomized to empagliflozin 10 milligram compared to placebo. And the primary endpoint, time to first event of cardiovascular death or heart failure hospitalization. And they have 2 key secondary endpoints: first and recurrent heart failure hospitalization, or slope of change in GFR from baseline. And it was a very successful trial. For the first time in HFpEF, we have a 21% reduction in the primary endpoint. Number need to be treated 31 with a very significant p-value. And what's interesting here, the effect was very early. In the first 18 days, we had early and sustained risk reduction in cardiovascular death or heart failure hospitalization. And in addition, we have lowered rate of total heart failure hospitalization and heart failure with ejection fraction more than 40, about 27%. It was positive both for diabetes and without diabetes. And the empagliflozin as well was showing a significant slowing in decline in the kidney function in the form of GFR slope. But if you see here the slide here and the curve, see early dip in GFR is expected. So once we start the SGLT2, we expect that we have early dip in GFR, and after that we'll pick up, and then we have improvement or less decline in GFR in patient treated with empathy. In this study, it was half that of patient treated with a placebo. If we put them together, Impero-reduced and Impero-preserved, to see the continuum of the ejection fraction, both were effective. This is an example of successful SGLT2 inhibitor. What about side effects? The adverse effects were similar in the study between the two groups. There was no statistical significant difference between the adverse effects. And last year, in August 2022, we have the dapagliflozin, and it showed almost the same results. The DELIVER trial for dapagliflozin was again designed to see whether dapagliflozin compared with placebo would reduce cardiovascular death or worsening heart failure in patients with mild reduced and preserved ejection fraction. And the primary endpoint was time to first composed of cardiovascular death or heart failure event, hospitalization or urgent ER visit. And they were, it was a large study, more than 6,000 patients, dapagliflozin 10 milligram compared to placebo. And it was, again, positive trial with 18% reduction in the primary endpoint for reduction of cardiovascular death or worsening heart failure. Similarity between Impero-reduced and DELIVER, both comparable relative risk reduction, 18% versus 21. Reduction, the composite slightly different. And the DELIVER trial, they include patient even with, patient with specified like ejection fraction less than 60%, and they include patient more than 60%. The point of 60% that in Impero-preserved, there was like attenuation towards 60%. So in Impero-preserved, the effect was lost if you go above 60% ejection fraction. However, we have the same reduction in heart failure hospitalization and no effect on cardiovascular mortality. The patient with improved ejection fraction, patient who was like previously was less than 40 and then improved more than 40, was not studied before, and in DELIVER trial, it was included and it showed a clear benefit. So we have a clear signal of benefit across LV ejection fraction categories in all categories of ejection fraction. So SGLT2 inhibitors with dapagliflozin is effective treatment for HFpEF and HFrEF, or heart failure with mild reduced and preserved ejection fraction, joins the empagliflozin and confirms the efficacy of SGLT2 inhibition. It improves outcomes in patient with improved ejection fraction. It was, again, safe and well tolerated in the study. I will not read the conclusion, but most important thing here, serious side or adverse events and adverse events leading to discontinuation were similar between dapagliflozin and placebo. So these data provide further evidence to support the use of SGLT2 inhibitor as foundational therapy in patients with heart failure, regardless of care setting or ejection fraction. In 2021, the European Society of Cardiology just the Imperial Preserve trial, so they didn't mention SGLT2 inhibitors, while the American guidelines in 2022, they include, they put them, or they give them as class 2A. I think in the new guidelines or the update, we'll have them as class 1. Because of now we have the DELIVER trial, so 2 trials, I think for sure they will get a class 1 recommendation. Now, caution is advised in patients with condition associated with an increased risk of DKA. Factors that increase the risk of ketoacidosis include severe dehydration, insulin dose reduction or failure to increase insulin with an acute medical illness, surgery. It's very important if you have a patient with for elective surgery, we have to stop the SGLT2 inhibitors 3 days before. We have to think of ketoacidosis. Now, SGLT2 inhibitor must be discontinued immediately if DKA is suspected. You know, the ketoacidosis in the SGLT2 inhibitors, DKA will, the glucose will be like euglycemic. So it will be like near normal, and we should depend on other symptoms to think about DKA, like GI symptoms, anorexia, excessive thirst, or difficulty in breathing, or confusion, or fatigue, or sleepiness. We have to think of DKA if we have a patient who developed these symptoms and he's in SGLT2 inhibitors. Genital infections with SGLT2 inhibitors are common, typically mild to moderate in severity and easily managed. We should raise the awareness that if you start SGLT2 inhibitor treatment to manage expectation, you know, the glucose will be high in urine, and then we'll have like rich culture. So we should give the proper practical hygiene advice to patient to prevent genital infection. So fortunately, we don't have usually a complicated genital infection in a patient with SGLT2 inhibitors. Point to mention that if you have a recurrence or recurrent genital infection, this is a contraindication. The same for DKA if the patient developed DKA. So SGLT2 inhibitor or inhibition is the game changer. Have evolved from glucose-lowering drugs with a pure effect on renal glucose reabsorption to cardioprotective drugs in a patient at increased risk of heart failure and to effective treatment for heart failure. It has like early effect on mortality and morbidity. These drugs should be implemented at any encounter with heart failure patient, regardless of background treatment, heart rate, blood pressure, kidney function. It reduces cardiovascular mortality and heart failure hospitalization, has early start of action, given once daily, no need for up titration, has mild side effects, but we should know them and how to manage them, and beneficial effect of renal function. And thank you for your attention.
بارك الله فيك دكتور ما شاء الله لا قوة إلا بالله. What a beautiful presentation. كانت عندي مجموعة أسئلة and I think you answered 110% of them.
شكرا.
بارك الله فيك والله يعني استمتعنا جدا بالمعلومات ومحاضرة دسمة very comprehensive and very complete. بعد إذنك دكتور صلاح أستاذنا الدكتور عبد الرزاق جهاني عنده a couple of slides that you'd like to share with us. Professor, are you with us?
Yes, I am. Can I share them at the very end when everybody's...
after, okay.
Yeah, but I have a couple of comments if I may.
Yes, please go ahead.
Thank you so much, Dr. Salah. If you look at the history of, forget for the minute, heart failure with the reduced ejection fraction, because we had earlier successes with ACE inhibitors and so on and so on. But we really were struggling with the stubborn heart failure with PRESERVE. So much so that when your patient comes to the clinic and he has a heart failure, you wish that the echo will show LV dysfunction. and not a normal ejection fraction, because if it is normal ejection fraction, you haven't got much to do. And alhamdulillah, now we have got this, at least opened the door. And I'm sure there'll be more progress on this. The heart failure would preserve LV function. The other comment is also interesting, how some drugs start in one area of medicine and then excel in another area of medicine. This reminds me, this shows my age now, this reminds me of very early times when amiodarone was introduced. I don't know if everybody knows that it was first introduced as anti-anginal. It was very effective anti-anginal medication, but it soon came out that it had so many complications, toxicity, and it was indeed a very good antiarrhythmic. So forget the angina, we have other options. And here, I think this SGLT2 are moving more out of the hands of endocrinologists into the hands of the cardiologists. Thanks so much to our endocrinologists and nephrologists for this offer. My question is two very brief questions. How safe, let's start with a quicker question. Prior to major surgery, a patient on SGLT2 inhibitors, prior to major surgery, do you recommend stopping it, or do you recommend continue but monitoring for side effects like ketoacidosis?
Yeah, thank you. The excellent question, Dr. Jani. Yeah, it's recommended to stop 3 days before planned surgery. It's recommended to stop it before the surgery, because we don't know what will happen, whether it will be a complicated surgery or no. Especially patient, the key issue, I should stress that it is for patient who is usually requiring insulin. This is, I mean, the decay is not that common, but I try to put it because usually saying there is no difference between the drug and placebo, but in the real world, we should take care because it might happen. And in this case, we should be prepared to treat.
And how is the risk of having a relapse heart failure?
Yeah, so the risk is well studied in the HF trial. So not for SGLT2 inhibitor alone, for all anti-failure treatment. And there was a small study, HF trial, and when they stopped the medications, then we have a relapse in around 40% of patients. So it's not recommended for all anti-failure treatment to be stopped at any stage, even after getting recovery.
Okay, a very last brief question about the safety of starting SGLT2 inhibitors as an inpatient.
Yeah, this is very excellent question, Dr. Jani. This is practical. Actually, I tried to be short and I didn't include everything because this is a very big subject. So the initiation of SGLT2 inhibitors were studied in 2 trials before, Cellulist for a medication called, or SGLT2 inhibitor 1 and 2 called sotagliflozin. It was started pre-discharge and then soon after discharge, and it was effective as well, but it was only for diabetic patient. What was the evidence now? We have the Impulse trial for empagliflozin. Impulse trial showed that it is very safe and effective to start treatment as inpatient. And in general, we love to have to start anti-failure treatment while patient hospitalized. That's good to look for any possible side effects. We'll see the renal parameters and vitals before going home. So it was studied actually in the Impulse trial, and it is safe to start it as inpatient.
Thank you so much, Dr. Salah. Over to you, Dr. Usama.
Barakallah fiqh, great questions and great answers, of course. دكتورة سامية ضيفتنا العزيزة، لو عندك أي زيادة أو أي إضافة أو توضيح أو أسئلة تفضلي.
Okay, شكرا دكتور صلاح على for this good presentation. Actually, SGLT2 in our field, we started it regardless of A1C, because it's weak as anti-hyperglycemic drug. Efficacy in type 2 without renal impairment, it's around 6 to 9%. As a monotherapy, it's reached up to 0.7% only. But if we use it as added on therapy, it's just 0.6 when estimated GFR above 60. But when estimated GFR below 60 up to 30, its efficacy becomes very weak, 0.3 to 0.4% reduction in A1C within 3 months, and no effect if the estimated GFR below 30. That's why we should start SGLT2 for its anti-diabetic action, and it's the only drug with GLP receptor agonist that give this chance for our diabetic patient to have cardiorenal protection. Actually, it's good drug, and you presentation is covered whole what we can say. Thank you, Dr. Salah.
بارك الله فيك. سامحونا خطفنا منكم الدواء هذا يا جماعة الكارديولوجي، ولكن يعني we're all on the same team looking for the best for the patient. ويعني صح بالحظ هو هذا طلع الدواء يعني very cardiac beneficial زي ما كان الفنان مش عارف تعرفوه بوب روس. Happy little accidents. It's a very happy little accident, but it's not so little. دكتورنا منير from all the way in New Orleans, Louisiana. تفضل إذا كان عندك أي إضافة أو استفسار.
Assalamu alaikum, Dr. Salah. It was a great presentation. Thank you so much. It's include everything. I just want to add one point, and I have two brief questions. So the point that I would like to add, there is also DABA CKD, like similar to the DABA HF. And it actually, one of the interesting things that 50% of the patients are not diabetic. And the composite endpoint was similar to diabetic patients. So that's very promising. And actually, here we started the patient on DAPA, even if they don't have diabetes. So hopefully that we're going to see the effect. The two questions, one for Dr. Sami and one for Dr. Salah. The question for Dr. Salah, have you started DAPA or EMPA for patients with the GFR less than 20%?
The cutoff for impaired reduce was 20. So personally, I'm not giving both EMPA or DABA for a patient who is less than 20%. Actually, for DABA, 30 GFR is the cutoff. Generally, we are using anti-failure treatments if it is above 30 to be safer, you know. Your point about DABA CKD, and you have also Dr. Munir EMBA kidney as well. So I didn't include them in the presentation because this is yours, and it was also effective in diabetic and non-diabetic. Now I know that you have a question to Dr. Sami, but I want to use this to ask a very important question. I didn't have the answer for it. Now, if you have a patient who have already established or end-stage renal disease, is going for dialysis, damage already happened. We see in that patient, I can see our nephrologist here giving ACE inhibitor or ARB without fear, while they are not giving the SGLT2 inhibitors. Whether it is safe, do you have any study saying that it's safe to give it for GFR below 15, for example, or patient who is going for dialysis? And is it safe, or is it in your practice?
Yeah, actually, I didn't see any nephrologist here or any study approves the start of the SGLT2 inhibitors in a patient with ESRD. as you say, the damage is already done. So there is no renal benefit unless if the patient has heart failure, and that's your plan to treat the heart failure. But again, that's why I asked you. So we don't initiate the SGLT2 inhibitors in patient with ESRD.
Okay.
Dr.
So
Munir,
my question for Dr. Samia, that's a quick question. In Libya, I mean, like, what's the availability of these medications? Are they accessible to the patients? Are they expensive or not?
Yes, actually, we started it since 2014 in a private sector. Just a few patients, they brought them from outside. But in 2018, we started at National Diabetic Tripoli Hospital. We start with the IMBA, and then we have both IMBA and DABA. You know, sometimes it's present in our governmental hospital. Sometimes they have to pay from outside as a private drug. Just I have a few comments for use of SGLT2 about estimated GFR. I think it's not allowed to be used at initiation below 45 in both. But because there is initial decrease in estimated GFR to up to 3 cc per minute, means it's just reduction of estimated GFR, which subsequently will be stabilized and will be as a renal protection. For its benefit, we find it more with the patient below 60 estimated GFR. But in our practice, we don't start below 45 as initiation.
Yeah. Can I comment, Dr. Munir?
Yes.
So, yeah, you're right for diabetes trial, Dr. Samia. This was the cutoff 45. For heart failure, it's different scenario. So if you are giving for prevention, the trials, the EMBEREG, Canavas, and DECLARE trial, the diabetes trial, they put cutoff of 45. And for a long time, it was like, you know, putting as this is the cutoff for 45. And if it is less than 45, then use GLP-1 agonists instead of SGLT2 inhibitors. Until we get to the heart failure with reduced ejection fraction trials, where they use 30%, 30 and 20 as cutoff. So in diabetes, yes, diabetes trial. In heart failure trials, the cutoff was lower.
Barakallah fiqh, Dr. Salah. Dr. Abdurrazzaq, I just want to learn from your expertise. And if I can give you a scenario of a patient that we probably all commonly see. Let's say a 60-year-old gentleman comes in with non-ischemic cardiomyopathy with an ejection fraction of, let's say, 30%. He's hospitalized and initiated on beta blocker and ACE inhibitor and discharged home and told to follow up with the cardiologist, but he didn't follow up. And his family doctor, let's say, or primary care provider orders an echo, let's say about 6 months later, and the echo comes back with a normal ejection fraction. Now, this gentleman starts standing on 2 pillars rather than 4 pillars. Is he going to fall, or do we have to initiate the other 2 pillars or not, the spironolactone and the SGLT2 inhibitors, or there's no need now, especially he's on 2 good LV-enhancing therapies and has a normal ejection fraction and asymptomatic? What do you do in this situation, Dr. Abdurrazzaq?
Very smart question. I'm not so sure I have the full answer, but I would like to do an MRI for this patient to just make sure he doesn't have cardiomyopathy that may tip him again into low ejection fraction. And I will go back and review the first echo too. Was this a myocarditis that has improved? Was this a mistake of the first echo or the second echo? So to organize myself, I would go back and look at the first echo. I would do an MRI to look at the myocardial structure for any signs of intramuscular disease. I think now he has good ejection fraction, and I assume he is asymptomatic from heart failure point of view. I would not go and put him on SGL2. I don't think there's guidelines to tell us yes or no, but I think in this scenario, I'd probably keep him on the 2 arms you've already started.
Barakallahu feek. Thank you very much. Dr. Salah, have you faced anything like this in your practice?
Yeah, we have now, you know, with the new era of treatment, the ARNI and SGLT2, a lot of improved ejection fraction. And until we get the DELIVER trial, this question was difficult to answer. But we have evidence now from DELIVER trial that if you start SGLT2 inhibitor in form of dapagliflozin in this study, it leads to improvement in the cardiovascular mortality and hospitalization. For heart failure with improved ejection fraction, is SGLT2 inhibitor in form of dapagliflozin is indicated. Now, depending on if we take a patient as symptom-wise, I think we have to be very careful, because these patients who would die suddenly, symptoms in heart failure and stability is a myth. So if it is safe, I will not discontinue the 2 medications, and if it is safe, I'll add the SGLT2 inhibitors just to maintain the improvement and keep him in proper treatment.
اوكي بارك الله فيك. عندنا أسئلة من زملائنا في الشات جروب. Dr. Salah, if you have any information about using SGLT2 inhibitors in patients who are undergoing chemotherapy that is cardiotoxic and may have drug-induced cardiomyopathy from these cardiotoxic chemotherapeutic agents. Any evidence?
I know there are like 2 trials, ongoing trials, but we don't have evidence yet that it's effective in this field. So we don't have the evidence yet.
Dr. Samia, سؤال ليك from a cardiologist who hasn't treated DKA for quite some time. How do we treat the euglycemic DKA in these patients? If they come to the CCU, for some reason, somebody does a troponin and it's high, and they get admitted to the cardiac unit, and then we end up finding that they have DKA, euglycemic DKA on SGLT2 inhibitors. Other than holding the SGLT2 inhibitor, is there any other steps in the management of this patient?
Yes, the risk, you should first prevent it. The risk of euglycemic DKA in patient using SGLT2, it's not so high, in a good hand. If you know the risk that if the patient fasting, avoid the dehydration, you should stop pre-operative 3 days before operation, and you should not stop their insulin, basal insulin. You are safe to coming to this complication. But if the patient presented with the euglycemic DKA, straight away I have to hold an SGLT2, and then we have to start with 10% dextrose and start fixed rate of IV insulin infusion according to the body weight of the patient, and monitoring ABG and the potassium as the usual on the treatment of DKA. But we have straightforward to start with 10% dextrose, because they are usually euglycemic, normoglycemic, or even low blood glucose.
Are they at? Is there a risk of higher than the usual DKA, the type 2?
Yes, it's difficult to manipulate, because during the usual hyperglycemia, while in DKA we provide better to use the IV insulin. We don't afraid from. We have to avoid the hypoglycemia. That's why we have to go straight for IV infusion with dextrose, 10% dextrose, with soluble insulin infusion, IV insulin infusion.
Okay. So let's say the patient recovers and does well. Can I reinitiate SGLT2 inhibitors in patients who have presented with a DKA.
Yes, we have to know why he enters into DKA. I had one case, they are stopping for them whole insulin, and you know that long-standing type 2 diabetes, they became insulin dependent. They stop whole insulin total daily dose completely. We have to continue with the basal insulin with SGLT2 inhibitor. If we stop this basal, the risk of euglycemic decay is high.
Okay.
If we know the cause, we could reconsider SGLT2 because it's benefit for the heart and the kidney. If we don't know the cause, we have to stop for them for SGLT2 use later.
Thank you very much. Dr. Salah, just a question from the audience. You mentioned that it's safe to start SGLT2 inhibitors as an inpatient. If the patient's coming in with an acute heart failure, let's split it to two. Newly diagnosed heart failure and known heart failure comes in with an exacerbation. Is it okay to initiate it in the acute phase while the patient is still symptomatic and volume overloaded?
Yeah, this is excellent question. Actually, this was studied in the impulse trial, as I mentioned, and it was effective. I think congestion is part of decompensation for de novo and or for non-heart failure patient. The SGLT2 inhibitors will work as diuretics, so it will work in this acute setting as well. The study was there was no time to wait for SGLT2 to be started like in beta blocker before discharge. The average waiting, I think, was like 1 or 2 days, and then they start the SGLT2 inhibitors, and this study was empagliflozin, and they use what we call win ratio, and the SGLT2 inhibitor, the empagliflozin, was the winner against placebo in this trial. It was safe, improving cardiovascular mortality, and the symptoms in form of congestion, quality of life for the coming 90 days after discharge. And before that, we were not sure whether it is safe to start SGLT2 inhibitors in patient or no. But then both saying, yes, you can start it as inpatient.
Barakallah, Doctor. Sual Dr. Munir. So we have a patient with a GFR of 40. We started an SGLT2 inhibitor. How do we monitor the patient's GFR or creatinine clearance? How often do we order blood tests initially and for future follow-up?
That's a good question. Initially, like the decline in the GFR, initial decline is expected in more than 30% of patients, but that should recover over weeks to the baseline. So usually we monitor the patient like every 6 months to see the decline in the GFR. If we didn't see benefit by 1 year, I doubt that patient will get any benefit after first year. So yes, initially we do labs within weeks after initiation just to make sure the decline in the GFR is not critical. Then every 6 months, that's what we do right now.
Okay. Another question from the audience. Is there any preference between the SGLT2 inhibitors? Dr. Salah.
Yeah, this is expected question. We have a meta-analysis done by Fayaz Zanad for impurity-reduced and DABA HF. They are similar in everything. Because I didn't mention that in the presentation, the cardiovascular death was achieved in DABA HF, and it was not achieved in impurity-reduced because the population were different. You know, the impurity-reduced were like sicker patient. So someone might say that, okay, then empagliflozin has no cardiovascular death or no improvement in cardiovascular death in empagliflozin. But if you go back and see the diabetes trial, EMPA-REG, it was exactly the opposite. So in EMPA-REG, the cardiovascular death for empagliflozin was like achieved, and DECLARE for dapagliflozin was not. So when they did a meta-analysis, both are working the same. It's a class effect. You just pick one of them. They are similar. Don't listen to anything else. DABA is equivalent to EMPA for everything. And no preference in DABA or EMPA. You just choose one of them.
بارك الله فيك. دكتور أبو سنينة، خلينا أعطوك المايك. Unmute yourself. دكتور أبو سنينة.
ايوه I'm trying to
تفضل.
ايوه السلام عليكم. شكرا دكتور صلاح. شكرا دكتور صلاح على المحاضرة. شكرا لجميع الحضور. أنا عندي سؤال بخصوص في ال patients with diabetic وعندهم already atherosclerotic disease or ولا ما عندهمش like without heart failure. Is there any like study compare head to head with the GLP-1 agonist? Which one you prefer يعني to start, especially for endocrinologists at second line treatment for diabetes and for prevention? يعني قارنوا ال SGLT2 inhibitor وال GLP-1 أن حتى أظن حتى GLP-1 عنده decreased cardiovascular mortality and all-cause mortality too.
Yes, in ADA guideline that prefer to use GLP receptor agonist in patient with the high risk of arteriosclerosis. But if the patient came with the cardiovascular disease or heart failure, he should be in SGLT2. But there, I think there is no head-to-head comparison. But both they are improving the cardiovascular mortality.
I think, Dr. Salah, you had a slide in the beginning which showed how to approach patients with very high risk. And you had those two arms, one with risk factors, one without risk factors, and it showed that the SGLT2 plus. So I don't know if you can pull that up very quickly. We can go back to it. But I'm not sure what evidence that was based on and what study that. Yeah, this one. The one, this one or the one above it, I think.
Sorry.
It's okay.
So, as mentioned by Dr. Samia, both medication improve cardiovascular outcome. Mainly liraglutide, liraglutide, one of the GLP-1 agonist, was very effective.
Number 8. Yeah.
Yes. So here, if we have a patient with established atherosclerotic cardiovascular disease or high or very high cardiovascular risk, then the choice between a GLT2 inhibitor or GLP-1, both are demonstrated in the leader trial for liraglutide and for the cardiovascular outcomes for SGLT2 inhibitors. Both showed that it can improve the cardiovascular outcome, and the choice here, as Dr. Samia said, if you have a heart failure or you want to prevent heart failure hospitalization, then you go for SGLT2 inhibitors, and if you don't have the risk of heart failure, then GLP-1. This is now the other thing that at that time when they put these guidelines, GFR was also a limitation. So GLP-1 can be used if you have a lower GFR less than 45. It will be like, a choice between the two medications. Both are effective and can be used in established atherosclerotic cardiovascular disease or very high cardiovascular risk.
بارك الله فيك دكتور صلاح. دكتور منير, سؤال أخير from a cardiologist. We want solid numbers. When should I not start an SGLT2 inhibitor? And when should I stop an SGLT2 inhibitor, like a GFR number?
Yes, so I believe for just to be safe for any GFR more than 30, it's safe to start it. And if you feel the GFR declining to ESRD, which is meaning less than 15, I believe it's better to stop it.
Barakallahu fi. I think we should probably stop by now. It's gone for about an hour and 20 minutes.
دكتور دكتور أسامة أعتقد في الدكتور عبد الرزاق الجهاني عنده 2 slides to share.
Yes, I know. Yeah. I'm with you. ولكن مجرد أبيات شعر بسيطة لضيوفنا الكرام، فإليكم الشعر البسيط هذا. الشعر أشرق وجهه وتهلل وتراقصت لقدومكم رتب العلا، والشطر في إيوانه متبسم والقهوة الصهباء دارت أولا، والقلب ذي نبضاته لو ترجمت لسمعت أهلا بالحبيب ويا هلا، يتزاحم الترحيب يسبق بعضه بعضا ويأتي بعضه متمهلا يختار أفضل حلة يكسو بها الألفاظ حرفا أجملا. فدكتورة سامية ودكتور منير أرجو
لحظة دكتور، هذا شعرك؟
هذا أمس بالليل صاهر نكتب فيه.
ما شاء الله. هذا ما شاء الله ما شاء الله
دكتور. لا ماخذه من النت.
من النت اوكي. لا ما شاء الله شكله شعرك.
يقول لي سخاءها ولا سخاؤها ما فيكون منها دول. هذا
لا ما شاء الله، هذا من البحر الكامل يعني، من
بارك الله فيك
البحور الفخمة.
بارك الله فيك دكتورة سامية ودكتور منير، أرجو أن تشاركونا في المحاضرات القادمة إن شاء الله، وتكونوا يعني معنا، لأن تدخلاتكم وآرائكم و your expertise is very valuable يعني. فشكرا لحضوركم.
إن شاء الله
نتمنى أن نتعاونوا مع بعض يعني من أجل الارتقاء ب يعني مساعدة المرضى وتحسين الظروف، خاصة في ليبيا. إذا كان في أي حاجة نقدر إحنا نساعدوا بها وأنتم تساعدونا فيها، فيا ريت نستمروا في التعاون هذا إن شاء الله. Professor Abdulrazak, please go ahead. The floor is yours.
Thank you. أظن Dr. Mohammed Al-Harari raised his hand for a comment. I don't know if he's still around and ready. I don't know.
Dr. Mohammed Al-Harari, I don't see any hands.
موجود دكتور محمد الحراري طالب ياخذ كومنت. دكتور محمد الحراري أنت ككوهوست ممكن تتفضل.
السلام عليكم ورحمة الله وبركاته. Can you hear me?
سامحني دكتور بشبحتش your hand، بس تفضل. أنت من العيلة يا دكتور.
بارك الله فيك. Can you hear me؟ معلش بس I want to check.
Yes, we can hear you loud and clear.
Okay. بارك الله فيكم. Salah, صراحة great talk. What can I say? Covered everything. I just want to say a few comments really about SGLT2 inhibitors just from my perspective. I'm sure a lot of you agree on this. This is to me, this is the new aspirin. This is the new statin. This is the class of drugs that came from nowhere. These drugs were not even in the guidelines in 2017, 2016 European or American guidelines. From nowhere. Now they're becoming more or less the first choice of all anti-failure therapy, regardless of ejection fraction. You know, this is a drug you give once daily, no titration, does not do anything. It does not affect your blood pressure, your electrolytes. If anything, you're less likely to have hyperkalemia if you give a SGLT2 inhibitor. Their benefit is completely independent of being on or off other guideline-directed therapy. It doesn't matter whether you can take the 3 or 4. You know, this treatment according to patient profile. This is a drug you can give it to anybody, basically. Really, there's no contraindication apart from type 1 diabetes. You can give it to people with GFR up to 20. And I heard a question about lower than 20. And I'm sure a lot of you agree that even if you start at GFR of say 24, and while you're on SGLT2 inhibitor, the GFR go below 20, you don't need to stop. You just do not need to stop. There's no indication to stop. You should not start it below 120, but if you're on it, do not stop it. It annoys me a lot when the drug gets stopped because somebody had a UTI. There's no really, it does not increase the risk of UTI. If you get a UTI, then you have to look after, your infection, drink water, whatever, hygiene, whatever. See a lot of nephrologists stop it because eGFR is less than 40, because that doesn't fit with their guidelines. Although, as you know, we have the EMBA kidney, we have the DABA CKD. It is very safe to be given during hospitalization, as Dr. Salah said, from the Impulse trial. You can give it as soon as the patient just off vasodilator or anatropes, even if they're still on IV diuretic within 6 hours, as long as you don't need to be increasing diuretic. So basically, you can start it almost in everybody next day they come in. And it is effective, it is safe, once daily drug. Cost may be an issue, particularly in our country. That's the only problem with it. That's all I want to say. I'm really a great fan of SGLT2 inhibitors, and they are class effect, I believe, with IMBA or DABA. Doesn't matter. Thank you.
بارك الله فيك دكتور محمد. خلاص أنا ناخذوه زي الأسبرين وخلاص إن شاء الله. تفضل دكتور عبد الرزاق. Like to share your screen?
Yeah, please. Can you see my screen?
I can, yes.
Yeah, it's really a materia non-medica. I would like to share with you a very impressive little thing, a little creature that beats all expectations. This little bird here, which weighs less than 250 grams, has traveled non-stop, and this record has been broken recently and published in 3 major scientific journals. 13,500 kilometers non-stop, and not on land. It's from Alaska all the way to Australia, almost in a straight line. The amazing thing, we always think that Alaska is way on the left side of the world and Australia is way on the right side of the world. And it just shows you how the world unites again on the other side. From Alaska to Tasmania in one go. The little fellow is called B6, and he's been fitted with a solar battery, a little detector, and connected satellites. This brings me to the verse. ربنا يقول ألم يروا إلى الطير مسخرات في جو السماء ما يمسكهن إلا الله ما يمسكهن في الهواء عاليا يطيرون إلا الله إن في ذلك لآيات لقوم يؤمنون. جزاكم الله خير وتصبحوا على خير.
لا إله إلا الله محمد رسول الله. سبحان الله وبحمده سبحان الله العظيم. بارك الله فيك دكتور. للأسف هنا في كندا الطيور يستخدموا فيهم في تهريب المخدرات من برا إلى داخل السجون. فالآن في حملة كبيرة على الطيور اللي هي تحوم حول السجون، مساكين يصطادوا فيهم. فلكن يعني بارك الله فيك على المعلومة الطيبة هذه، وشكرا جزيلا للإكسبرت بانل، وشكرا جزيلا للدكتور صلاح، وشكرا للحضور، وإن شاء الله نكونوا ما قصرناش معاكم وسامحونا إذا كان قصرنا. إلى اللقاء إن شاء الله في موعد آخر يتجدد. والسلام عليكم ورحمة الله وبركاته.
عليكم أفضل السلام ورحمة الله. تصبحون على خير يا جماعة.
السلام عليكم ورحمة الله وبركاته.
عليه أفضل الصلاة والسلام.